Dr. Jasmeet Mokha. He's come from the other coast, or near the other coast. He is an assistant professor of pediatric gastroenterology, hepatology, and nutrition at Connecticut Children's Medical Center, University of Connecticut in Hartford. And he has become interested in parenteral nutrition in kids, and that's great. So, congratulations on your award. And Dr. Mokha will be talking about effects of ethanol lock therapy on central line infections and mechanical problems in children with intestinal failure. Dr. Mokha.
Thank you so much. So I'm going to talk about some of our research that was published last year in JPEN with effects of ethanol lock therapy on central line infections and mechanical problems in children with intestinal failure. So we probably, you guys have seen this slide before. We know that CVCs are a lifeline for children who need parenteral nutrition for growth and development. One of the biggest factors that adds to the morbidity and even mortality is catheter-related bloodstream infections. We know, we think that they originate from biofilms that don't only form on the inside of the catheters, but also on the outside. And these organisms which are within these biofilms are more resistant to antibiotic therapy, anywhere from 10 times to even 1,000 times. And we know that there is a bunch of literature on the success of prophylactic ethanol lock therapy in prevention of these infections. So why choose ethanol? We know that it's a commonly used disinfectant. There is a good study that shows that 4-hour exposure to 70% ethanol is bactericidal and fungicidal. So it will kill both bacteria and fungi by affecting their cell membrane. It also has some fibrinolytic properties, so it prevents clot formation. And we are not, as of now, aware of any bacterial resistance to ethanol. It's inexpensive and readily available, though shortages have been reported. With respect to therapies, when we look at ethanol locks, there is no standard. Every institution has its own variation. Anywhere from 30% to 70% are used. Dwell time anywhere from 2 hours to as long as the patient is off of parenteral nutrition. Anywhere from once a week to daily, and it can be used to prevent infections in a primary or secondary prophylaxis. What that means is somebody who's never had a line infection can still go on ethanol lock therapy as long as you have that window, versus you wait for somebody to have an infection and then start the therapy, since we know that some kids are at a higher risk based on what the underlying disorder is, number of surgeries, anastomosis, etc. So we instituted the ethanol lock therapy protocol in March 2012. Before that, all our kids were getting heparin locks. We did note that there was a significant change in the rates of mechanical events, breakages, occlusions, necessitating replacements. So we decided to look at this. We record data in a prospective manner on all the children that we follow in the intestinal rehab program. And we compared the rates of infections, mechanical problem, what kind of mechanical problem, how many led to replacements in this study. So all the children were PN-dependent pediatric patients, and we collected data for over 8 years. And they could have been in the hospital versus at home, so there was continuity of data. Most of them had a single Newman Broviac, and I think 1 or 2 had PICC lines. And all of the catheters were silicone catheters. In our protocol, we use ethanol as primary prophylaxis. We put in, based on catheter size, we use 1 to 3 mLs of 70% ethanol. In this study, we instill it daily, anywhere from 2 to 4 hours. Once the 4 hours are up, we withdraw the ethanol, flush the CVC with normal saline, and if there's a gap that is more than 4 hours, so if a child is off of TPN for 12 hours after the 4 hours, after flushing, we put a heparin lock in. So heparin lock were used in patients before the ethanol lock therapy implementation and between periods which were longer than 4 hours. Similar to ethanol, 1 to 3 mLs of 100 units per ml heparin was instilled. And then similarly, before any infusion, they were flushed with normal saline. So to look at, we divided these patients into groups. So ethanol lock negative period was when the child was only receiving heparin locks. Ethanol lock positive was when they were receiving ethanol lock therapy for 2 to 4 hours, maybe plus heparin. And then we had a group of patients that were not receiving ethanol lock therapy, and then after the implementation of the program, they started receiving ethanol lock, so they could be compared to themselves on what the infection rates were, what the rates of mechanical problems were. So we had 29 patients with a median age of 2 months. We had around 10,000 catheter days. 13 patients had a pre and post ethanol lock therapy period. Neck was the most common diagnosis, followed by gastroschisis, and this chart shows the other diagnoses. So if we look, so this is numbers that, this is a table that looks at numbers when before ethanol lock therapy and after ethanol lock therapy, and clearly highlighted in red the mean rate of infections, which is events per 1,000 catheter days, was down. But the number of mechanical problems shot up from 1.4 per 1,000 catheter days to almost 7 per 1,000 catheter days, and both occlusions and breakages were up. And looking at replacements, so replacements due to infections went down, and the replacements due to mechanical problems shot up. And again, both occlusions and breakages. We also had some increase in the number of repairs that were done. So this chart is looking at the organisms. Overall, most of the infections, each organism was down. We didn't compare. We didn't do any statistical analysis. This is just for reporting. So this is a survival curve, looking at how long a catheter can survive without a mechanical event. So the solid line is when you're on no ethanol. The dotted line is when you have ethanol in your catheter. Each event, what happens to the line is when you have each event, it drops down. And how acute the drop is tells you how significant the events are. So what we can see is, comparing the solid line to the dotted line. So the solid line being the no ethanol versus the ethanol line, there is an acute drop when you put in ethanol into a line. So the event-free survival, so mechanical event-free survival decreases. That means you're more likely to have a mechanical event when there's ethanol in your line. So the average lifeline of a catheter decreased from 291 days to 114 days when you put ethanol in it. And 75% of all mechanical events led to catheter replacements. So now we're looking at these 13 kids who had a no ethanol period and then an ethanol period. And again, around 3,000 days, 3,000 catheter days of both periods. The rates of infections, again, are down because we put ethanol in it, but the rates of mechanical problems from almost no mechanical problems shot up. Again, occlusions were high and breakages were higher as well. Again, similarly, replacements due to infections went down, and replacements due to occlusions and breakages went up. So this is a graph showing, again, the 13, each diamond or a square represents rates in each of the 13 patients. So the left column, yes, the right column for you guys, is infectious replacements. So replacements in catheters due to infections. And going from the right towards the left, the rates of infectious replacements are down. And when you go to the next side, which is on the left side of the screen, is mechanical replacements. So replacements due to mechanical problems, which were almost unobserved in the pre-ethanol period, just shot up in most patients. So 7 out of 13 patients had issues with mechanical problems after we started putting ethanol into their catheters. So we did learn lessons from our ethanol lock therapy protocol. we did realize that it was probably too aggressive. So we wanted to make changes, and the rationale was that we want to limit exposure to 70% ethanol. And the other thought was that there is probably interaction between heparin and ethanol, and the separation is only by maybe half an hour, 1 hour, and the flush is only 10 mLs of normal saline. So we were sure that there was some mixing. So what we did was decrease the frequency from daily to 3 times a week, and dwell time, instead of 2 to 4 hours, we dwell the ethanol for the entire window period. So you would have ethanol, and then the flushing, the TPN, and the next day would be a heparin lock. And we did notice that the rates of we don't have formal data for it, but we know from our experience the mechanical problems, the rates of mechanical problems have really gone down. So in conclusion, we think while ethanol lock therapy is associated with low rates of catheter-related bloodstream infections, we do need to investigate the overall risks and benefits. In addition to investigating what the ideal concentration is, we need to look at the duration of ethanol lock therapy, timing, and even primary prophylaxis versus secondary prophylaxis, patient selection, and also we need research to develop solutions that are non-ethanol based. These are my references. Thank you.
All right, do we have any questions? Need a mic right there.
Hi. So I was just wondering, clearly because the median was 13, or still in the 13 months, they were young. They probably had really small IVs too, right?
Correct. So the two diameters that were used in our study were 2.7 and 4.2. So
Okay.
the older kids had 4.
So there's not really any research or data based on larger lines and, for older
Correct,
patients. Okay.
Has your team looked at antibiotic locks such as gentamicin? Because of a personal experience of using ethanol locks, we saw the same kind of trend of reduced infection but increased mechanical errors, and to the point where occlusion would happen and it would be a hit or miss if I would be able to flush the line, and it would be just playing around with heparin to try to get the line to be patent again. So we completely switched to gentamicin locks, and now that is what I've been using for a couple of years now, and we've had great results with it. No occlusion, no mechanical problems ever since. You did say on your last slide that you're looking at new options or new treatment regimens in replacement of ELT. What are some of those that you can mention today?
Right. So so one of the options is adding a polymer of ethanol. So so you decrease the ethanol concentration to 35%, and you add isopropyl ethanol, which is another 35%. It does not have what we think is the protein coagulation properties, and ethanol coagulates proteins at 30% and above. So if you decrease the concentration, there is 2% taurolidine, which is a chemotherapeutic agent which also has antimicrobial properties. There are antibiotic locks that are coming up, for example, minocycline, which is mixed with a lower concentration of ethanol, which can be left in for as long as the window period. And these are the 3 that we are looking at. However, since we made these changes, so I think the biggest, and if you look at most programs that have published on ethanol lock therapy and complications, what seems to be kind of similar between the studies is use of heparin and ethanol. How long you separate it. There are programs that have completely eliminated heparin from the TPN. They don't use heparin locks. They've eliminated heparin from TPN, and their occlusion breakage rates are pretty much 0. And we've seen a big change since we separated heparin and ethanol, and I think the move is towards removing heparin altogether.
Yes, I have a question regarding Vanco locks. My daughter recently was put on Vanco locks due to the incompatibility with ethanol in a new line that she was given that is not silicone. Do you have any experience with Vanco locks in
We,
silicone?
Since I've been at this program, we do not use antibiotic locks frequently. I know that the oncologist and the ports and for intestinal failure patients we do not use antibiotic locks. We are pretty much married to ethanol locks.
Do you have a recommendation if they have a polyurethane line versus silicone
So
for a
yeah,
lock?
so polyurethane. So you're right. Ethanol cannot be used in polyurethane because it causes cracks, microdegeneration, etc., etc. So then most of all of our patients have silicone catheters. That's what our surgeons insert. But usually the oncologist will use vancomycin locks. That's what they use. But I don't have data on how well the infection rates are controlled.
One of the problems with the antibiotic locks, a lot of the infectious disease people are very concerned about that much use of antibiotics because of bacteria being able to become bigger and better and resistant to many of the antibiotics. So, yes.
This is a question that relates to maybe a postulated cause of the mechanical failures, and you alluded to the fact that there is a relationship between the ethanol concentration and protein precipitation, which is pretty well documented, and it's a concentration dependent phenomena. Have you looked at the lower concentrations? Because when you look at 70% versus 28%, there's a significantly different rate of protein precipitation. So have you looked at the lower concentrations and then correlate those to the mechanical complications of occlusion?
We have not. But the issue with the lower concentration is there is no published literature, at least for its antimicrobial properties. So the study that the ethanol, the entire dwell time and concentration of ethanol comes from, to my best of my knowledge, from one study which inoculates these plastic adherent organisms for 1 hour or 4 hours. And for 1 hour, certain species like Candida, Klebsiella, and Pseudomonas, they regrow. So it's bacteriostatic, not cidal, but at 4 hours. And they report that 30 to 100% was effective, but the rest of everything else was done using 70% ethanol. So it would be a trial and error and not really based on science. But there are certainly programs that are using 30%, 40%. I've heard 50%. But like I said, at this point, we are pretty happy with our rates because mechanical problems are pretty low, and infection rates haven't gone up.
I just wanted to say, first of all, thank you. One of the things I've been struggling with is we've been hearing about ethanol locks, and then we take it back to our practice groups, and there's no research on this. So anything that we can point to, I would say anecdotally, I have a port, and with repeated infections, I've been using ethanol locks. What I found was, first, it was hard to get a silicone port, right? But once I covered that hurdle, the line attached to the Huber is degrading and actually breaking while I'm infusing. And so that was something that we now had to come up with a new protocol, and we've worked with that by basically doing the ethanol lock, and then after the dwell time, removing that Huber. So that is never used for therapy after the lock. But these are the types of things that nobody in my practice group, I'm in a very large home care agency, they didn't have any other consumers that were doing this. So these are just anecdotally, we're all having to sort of troubleshoot. But multiple times while I was infusing after the lock, the line would just bust and there would be TP, and I wouldn't know, right? It doesn't alarm. TPN goes all over, then you're leaking blood. So, and here we're trying to stop an infection, and now we have a busted line. You didn't have any of your patients that had ports, is that correct?
Correct.
Okay.
Yeah, but we do get reports of ballooning and all those things. I mean, there is good evidence that ethanol will affect silicone catheters also, and the authors of that study concluded that it was at higher forces than you would generally use. But the thing is that occlusions and breakages can go hand in hand. You have an occlusion, you use higher force to overcome that occlusion, and that causes a break. So many of these things go hand in hand, and you could argue that a crack then leads to an occlusion, then leads to a break. So ethanol does have, so like lower concentrations need to be studied, but infection, you have to compare morbidity to another morbidity.
In Europe, they're using taurolidine.
Yeah.
Is there any chance of proposing a study and getting taurolidine in your?
So the results for this agent are pretty encouraging, and there is no changes in mechanical properties. It's just it needs a culture change and a big number of patients, and you have to look at them prospectively. And you would start with the patients who are not that sick, don't get line infection. The other thing is ethanol also is not for everybody. We're preventing biofilm formation on the inside of the line, but the outside is still a source of bacteria, emboli, infections, etc. There is an older study that shows people with underlying dysmotility, so chronic intestinal pseudo obstructions, they do not benefit as much from ethanol locks. They still have bacteremias and infections related to central line.
Thank you very much. And we're so happy to have you come across the country to present your data.